En las escuelas de arquitectura hay fantasmas, ¿ok?, que poseen a los estudiantes. Al menos los que logran pasar el segundo o tercer periodo, indefectiblemente caen. Yo no explico de otra manera la devoción, el compromiso que asumen los estudiantes de arquitectura en una carrera como esta. La posesión ocurre en el taller. El taller es el espacio donde se da eso. El lugar que se va convirtiendo en tu espacio total, en tu hábitat total, ¿no? Ocurre por contagio, como los virus. Sin embargo, no se transmite fuera del aula. Es como si el fantasma estuviera confinado dentro del aula, dentro del taller de arquitectura. ¿Es dañino? Mira, no sé. ¿Tiene cura? No, definitivamente no. Si te tocó, nada va a volver a ser como antes. Para ti no tiene sentido juntarse con la misma gente, hacer lo mismo y a contar los mismos chistes. Deja de tener sentido. Las parejas son las primeras que lo sienten y a veces no le vale ni siquiera quedarse contigo cortando palitos la tarde entera. Hay un día que ellos te ponen a brillar, te hacen sentir invencible. Viene con el gesto de un profesor que te dice algo sobre algo que hiciste bien o algo así, o con una buena nota que tú no esperabas sacar y que nadie más sacó. Ese día tú explotas de alegría y dura hasta la próxima vez. Añoro tropezarme con esos objetos en el aula, en el pasillo, feos, bonitos, interesantes, sorprendentes, asombrosos. Y me angustia que todo esto está acabando con el fantasma de la escuela. Si no tienes piernas, corre. Si no tienes palabras, escribe poesía. Si no puedes salir, imagina.
Aún en tiempos difíciles, Sigue adelante. Continúa preparándote. Para los que creen en el futuro, Universidad Nacional Pedro Enrique Sureña.
Serena. Her presentation will be primary bone tumors, understanding these rare adult and pediatric and treatment options. Dr. Serena is a fellowship-trained oncology orthopedic surgeon and pediatric orthopedic surgeon at Miami Cancer Institute and Miami Orthopedic and Sports Medicine Institute, both part of Baptist Health, South Florida. Dr. Balserena earned her medical degree at the University of the Republic College of Medicine in Montevideo, Uruguay, and completed a residency in orthopedic surgery at Santa Casa of São Paulo, Brazil. She then completed 2 orthopedic oncology fellowships at the following highly respected institutions: Memorial Sloan Kettering Cancer Center in New York, and the Moffitt Cancer Center in Tampa. The pediatric orthopedic surgery, she conducted her fellowship study at the Hospital for Specialty Surgery in New York. Dr. Balserena specializes in the surgical treatment of musculoskeletal tumors, including benign and malignant bone and soft tissue tumors, with a main interest in limb salvage procedures and metastasis. She also manages the orthopedic problems that can arise in oncological patients, such as pathological and atypical fractures, avascular necrosis, and osteoporosis. Additionally, Dr. Balserena is specialized in pediatric orthopedic surgery, especially pediatric fractures, limb abnormalities, hip and foot disorders, pediatric bone and soft tissue tumors, and orthopedic care of cerebral palsy. She is actively involved in clinical research and in the increase of efficacy of treatments and improve patient outcomes. She has published in peer-reviewed medical journals and lectures of national and international academic symposium. She is a member of the American Academy of Orthopedic Surgeons and Musculoskeletal Tumor Society. Dr. Balserena is fluent in English, Spanish, and Portuguese, and French. Please let's give a warm welcome to Dr. Ana Balserena. Welcome, doctor, and thank you so much for joining us.
Hi, hello, everybody. Thank you so much for the opportunity to be here. It's an absolute pleasure to be sharing a little bit of my universe with you guys. So I'm gonna be talking during 20 minutes about very rare diseases. So I wanna bring my rare diseases world to something you can translate and use in your everyday life. So I'm gonna start by sharing my screen with you guys so you can see my presentation. Right here, perfect. Okay, here we go. So today I'm gonna talk to you guys about primary bone tumors. So first of all, like, who am I and why am I talking to you guys? So I had a great introduction by Dr. Gales, but I'm an oncologist orthopedics. That's basically what I do. So I treat primary and secondary bone and soft tissue tumors. And not many of you may know what an oncologist orthopedist is. In fact, what we do is so rare. There's only 200 of us in the United States. So we specialize in the diagnosis and treatment of primary, benign, and malignant tumors of the bone and the soft tissues. So bone tumors are quite an extensive world. You can find all kinds of tumors. And every couple of years, the World Health Organization changes a little bit the classifications and adds new diagnoses, new tumors. So it's kind of like a changing universe that we need to keep up with. So to make a big distinction, what we do in order to understand these diseases better is we try to classify them and putting them in little groups, because there are so many tumors. They're so different among them between prognosis and treatment and how they behave. So first, there's a big distinction that we do between primary bone tumors and secondary bone tumors. When we say secondary, we mean tumors that travel from somewhere else in the body to the bones. And in that case, we're talking about metastatic disease. For instance, what you can see here in this picture is, for instance, breast cancer. So the person has this tumor in the breast, and through the different pathways, tumor cells can travel along the body. And because of the environment they find in the bone, they stay there and they grow and they create a new tumor inside the bones. That's a secondary bone tumor. Today, we're going to be addressing primary bone tumors, which is tumors that start in the bone. They're not coming from a different organ, but they're actually arising in our bones. So that's a little more on metastatic disease. That's once the tumor cells get to the bone, there's a very fluid interaction between the bone and the tumor cells, and that's going to give the outcome if that tumor cell is going to make bone production, or it's going to reabsorb bone. And that's why we see metastatic disease. Maybe the med students have seen like lytic lesion and sclerotic lesions. That's why. And that's kind of what happens to our bones. When we have a lytic lesion from a cancer coming from somewhere else, it weakens our bones. So that's kind of a secondary bone tumor. So going back to the primary bone tumors, we can divide those between benign and malignant. What decides on what's benign and what's malignant is the potential to metastasize that a lesion has, the aggressiveness and the possibility of going to other organs. So again, the World Health Organization also tries to classify these tumors, that there are so many in smaller groups. So they're going to be classified according to what substance we see once we put this tumor in the microscope. What are we seeing? Are we seeing cartilage? Are we seeing bone? Is it marrow cells like lymphoblasts? What are we seeing there? So as you guys know, we have different type of tissues within the bone. Sometimes it's hard to explain to patients because they have this idea that bones are kind of like a piece of wood, and it's not. There's like very vital structures with different tissues, and a lot of things are happening in our bones. We're growing, we're producing blood cells, and all of those tissues we find within the bone. We can have different tumors arising from them. We have tumors arising from the cartilage. We have tumors arising from growth plates. We have tumors arising from the bone marrow. So we're going to see a few of those ahead. The thing with these tumors that is good for us is that they behave in a predictable way. They usually tend, the same kind of tumor tend to present in the similar locations, in similar parts of the bones, and they kind of behave in a similar fashion. So that's good for us to help us in making those diagnoses, because there are so many of these tumors that you guys are gonna see in a little bit. So luckily for us, they tend to have similar presentations. So for instance, if you're talking somebody about 30, about 40, and we have a new lesion, be very careful of those. Kids can present with new lesions and those be benign, but if you're talking an adult, it's very odd to have a new lesion. So in those cases, you have to be thinking like, what's going on with that bone for something to be happening at 45, at 50 years old. So one of your first differentials are gonna be malignant diseases. And in that case, the most frequent is gonna be metastatic disease. Now, if you're talking about somebody younger, less than 30, we have a different subgroup of diseases that we're going to consider in that age range. Also, the location in the bone is going to guide us towards diagnosis. We know, for instance, towards the end of the bone, what we call the epiphysis, we have in a kid, we're going to think about chondroblastoma. If we're dealing with an adult, we're not going to think of chondroblastoma as the first option, but we're going to think about giant cell tumors. So those are little hints that are going to help us and guide us towards the diagnosis. It's very difficult for a general physician, for a med student, just seeing an x-ray to understand what's going on. But if you at least can subgroup the diseases based on the age and the location and have an idea if is this benign or malignant, you're already helping the patient a lot. So the other things I was saying, age groups, these lesions, they have a tendency to distribute at certain ages. So for instance, if we're talking about a kid and we see a very well-defined lesion, we're gonna think simple bone cyst, or we're gonna think eosinophilic granuloma. Now, if we're seeing a lesion that is not well-defined, it looks like moth-eaten, then that's something more concerning. We're gonna think about an Ewing sarcoma. So age and the appearance of those tumors are very important in guiding us. We're going to start talk a few about benign bone lesions first. So those are the kind of diagnoses you're going to see most frequently, in the ED, or if you start a family practice or you're a primary care physician, those are the most common ones you're going to see. And what is the characteristic of these tumors is that once you put them in the microscope, you see mature bone. That's what you're seeing here. The pinkish area is the osteoid. And within that, you find the osteocytes, and on the borders, the osteoblast. So I think some of the med students are familiar with those. So we actually see those in the microscopes, and that's how we know this is not malignant, because we see mature bone. It doesn't matter how the lesion looks on the x-ray, they look very different among them, but on the microscope, you see mature tissue. So for instance, this is an osteoblastoma. They usually present in pediatric patients, usually in the long bones. Some of you may not see what I'm seeing here, but I'm gonna show you a CT scan. So sometimes you're just gonna see some periosteal reaction. Periosteal reaction is what we see when the periosteum is enlarged or showing some changes, and that's telling you the bone is reacting to something. Is either trying to contain it. We can find it in different situations. For instance, if you have a chronic infection, your bone may try to contain that pus by doing a periosteal reaction. And the same thing with a tumor. The bone senses there's a tumor there and tries to contain it. So that's why you see an increase in the periosteum. So those patients, and these tumors present with a characteristic pain that is worse at night. It's very bad pain. That's how patients describe it. But at the same time, it gets better with an aspirin. So that's the good thing about these tumors. The pain is being caused by prostaglandins. So just by giving them NSAIDs, the pain at least is going to be better. So as I was saying, they usually present in pediatric population and teenagers. And here you can see the most common bone locations. The most frequent spot in the body is the femur, but you can find it everywhere, even in the spine, in the clavicle, everywhere. Potentially any bone in the body can have an osteoblastoma. Here is what we see in the CT scan. So these tumors are characterized by having a nidus. That's the center of the tumor. That's what you can see here in the CT scan. So that's actually the tumor, and what you guys were seeing on the X-ray is the reaction of the bone to contain that tumor. So sometimes it's very hard to see on an X-ray, and it looks quite concerning just by looking at the X-ray. But if you ask the patient and you find out how's the pain, is the pain presenting, what is making the pain better, you can suspect an osteoblastoma, and by getting a CT scan, you can actually see the tumor. The other most common primary bone tumor is an osteoblastoma. Osteoblastomas are very hard to tell on imaging because they have a very different types of presentation. They can look like that, but they can look like completely different, like destroying an entire humerus or a very small lesion in the middle of the femur. So the appearance of an osteoblastoma is not what's going to guide you the most. Usually for those kinds of lesions, we're going to need a biopsy. The treatment, since they are benign, we just correct them, or we can cut the entire bone and take it out. The problem with these tumors is they tend to recur locally. And that usually happens because since it's a benign tumor, we try not to be that aggressive with surgery, just not to damage a lot. Remember, we're dealing with benign and we don't want to cause any harm to the patient. So sometimes we choose to preserve a structure like a joint and do less curettage. So that's why this tumor keeps coming back. Another very frequent lesion that you guys may see in your patients in the ED, in the pediatric clinic, is what we call an osteochondroma. So this is a benign tumor. It's usually a growth coming outside the bone. What we see when we're looking in the microscope is mature cartilage and mature bone. Some people say those tumors happen when we are developing, and part of the growth plate just displaces and attaches to another spot and creates another growth of bone. So they usually grow, since they are part of our growth plate, they grow with us until we are growing. Once we stop growing, because we reach 16, 18 years old, they stop growing with us. In most cases, we're only gonna find one of these tumors in the body. And this is what I was talking about. This is what you see when you find one of those osteochondromas. They have this cartilage cap that's part of our growth plate and normal mature bone within. What's important to talk about these tumors is that they communicate with the rest of the bone. That's a very distinctive feature that you have to look in imaging, basically to differentiate from something more aggressive like an osteosarcoma. And you can see here on the cuts from the CT scan that there's actual communication between the actual within of the bone and the tumor itself. And I said, in most cases, they present as only one lesion, but we do have cases when we can have multiple osteochondromas, and that's what we call multiple hereditary exostosis. It's a syndrome. It's associated with a genetic translocation. And the problem with these tumors is that they can be associated with an increased risk of cancer. We don't know exactly what's different between one osteochondroma versus multiples. But in those patients, we know they have an increased risk of turning into a chondrosarcoma, which is a more aggressive tumor. It's actually a malignant tumor. So different from the solitary ones, those can keep growing even when we are adults. And the problem with those is that they're gonna rub against tendons, against muscle. So that's gonna bother the patient. That's why we end up taking this more often than when somebody has just one. So, because remember, this is a benign tumor. So the patient does not necessarily need surgery unless it's bothering him. Then this one is actually very frequent, the non-ossifying fibromas. So, and then we have a cousin of the non-ossifying fibroma, which is the fibrous cortical defect. We estimate about 30 to 30% of kids have those kind of lesions. The thing is, they are asymptomatic. So the patient fell, had a car accident, and then got an x-ray for another reason. And then people see those images and they can look concerning if you're not familiar with them. I'm gonna explain a little more about the characteristics they have on imaging. So they're usually eccentric, meaning towards the sides of the bone. You can see a sclerotic rim. Having a sclerotic rim on x-ray is something, is always like a reassuring sign. It's telling you whatever you have in there is either not growing or growing slow enough for your bone to react to it and contain it. Now, aggressive lesions like metastatic disease and cancers, they grow so fast, your bone cannot contain it. So that's why you see these irregular borders. You cannot see where the tumor starts and when the tumor ends. So that's a very important sign for med students when they are in the ED and they just see an x-ray for the first time. Most of these lesions are going to be around the knee. Also, the distal tibia is the second most common location. And like osteochondromas, they can also present as multiple lesions. In those cases, they're called the Jaffe-Campanacci syndrome. Usually, those patients are diagnosed very early as a child because they have multiple café spots, they have endocrine problems, they have cognitive impairment. And when you do x-rays, they have multiple non-ossifying fibromas all over their body. Those lesions, different from osteochondromas, they do not turn into something more aggressive or malignant. So you basically just observe them. So we talked a little bit about the most common benign primary bone tumors. So now we're going to talk about the primary malignant bone tumors, and that's what we call bone sarcomas. They're synonyms, they mean the same. So sarcomas is a very wide group of tumors, and what's common to them is their origin. They all start from mesenchymal cells. So when I give lectures about primary bone tumors, there's this concept, students ask me, oh, so those are cancers of the bone. Well, not necessarily, because the origin is in a mesenchymal cell. So you can actually have what we call an osteosarcoma, which is a bone sarcoma outside of the bone. So it's not the bone what's going to determine these tumors, it's the mesenchymal cells. So you can have an osteosarcoma within a muscle and not in one of your bones. Again, this is a huge group of tumor. I'm going to mention to you guys the most common ones so you're aware of them. They also, well, they can have chromosomal translocation, some of them, that luckily we can use that to target and treat them, but they're a very wide group of tumors. Also, I want you guys to leave this lecture with the idea that sarcomas can happen anywhere. It's the mesenchymal cell, it's gonna be the origin, and when we put that tumor in the microscope and we see what kind of tissue it resembles, it's what we're gonna call it. So if we see fat cells in the microscope, we're gonna be talking about a liposarcoma. If we see something that looks like a vascular structures, then we're gonna call it a angioendothelioma. So it's gonna depend on what we're seeing in the microscope, what's the matrix of that tumor, what is surrounding that cells, what are the most common cells. So if we can have look at a tumor like of those and look and see cartilage, and then we're gonna call it chondrosarcoma. But they're not limited to the bones. That's the idea I want you guys to take. The most common sarcomas of the bone that they usually present most commonly in the bone, but we can still find it elsewhere, are the chondrosarcoma, Ewing sarcoma, and the osteosarcoma. So in adults, the most common one is the chondrosarcoma, followed by osteosarcoma and chordoma. So chondrosarcoma, as I said, is because we're gonna look it in the microscope and we're gonna see cartilage. Osteosarcomas is because, again, we're gonna put it in the microscope and we're gonna see osteoid. But different from the benign tumors I mentioned earlier, this kind of osteoid that we're gonna see is immature. It looks aggressive. The cells look angrier, different from an osteochondroma that we're gonna see mature osteoid that's gonna look basically like normal bone. And then this is kind of the classical presentation. They usually present in teenagers, and most of them are around the knee. So there's a theory that they present between 10 and 14 years of ages as the most common presentation, that is linked to growth. They present near the growth plate, and there's a theory that is because the bone is growing so fast that some of those cells can mutate and turn into a tumor. But that's what you have to see. You see this teenager, 10, 12 years old, coming with knee pain and a knee mass. Just get an x-ray just to be sure. In terms of signs and symptoms, the good thing about bone sarcomas is bone is a rigid structure. So if you have something growing in there, that's going to increase the pressure in your bone and it's going to cause pain earlier. Versus when you have a soft tissue mass growing, sometimes they can be quite large before they start causing symptoms to the patient. And most of them present with pain at night, pain that doesn't gonna go away. When they grow to a certain extent, they can also present as a mass, but that's very later in life. It's more common for the patient to have the pain first, because these tumors are gonna increase the pressure within the bone and may also even cause a fracture in the bone. And most of them, 50 to 60%, are presented in the lower limbs. So who treats those kind of lesions? Because they're very rare. For instance, in the United States, we have about 600 osteosarcomas a year. So they're not very frequent. So it's a team. It's not just one doctor that's gonna treat those patients. So we're gonna need a radiologist that's gonna help us with reading the images, usually try to see, is the tumor invading critical structures? For instance, a tumor in the distal femur, is it invading, encasing the popliteal vein? Can we save that leg or not? Then a pathologist is going to help us assess the grade of the tumor. Malignant tumors are graded 1 to 3 based on what are we seeing on the microscope, like how many mitoses, do those cells look similar to one another, do they look very different? And that's going to tell us how aggressive the tumor is. Then it comes our part, we are the surgeons, so we're going to see, can we cut this tumor, can we cut the tumor and keep in the limb? A long time ago, like about in the 70s, all these tumors used to be amputated because we didn't have a better treatment option. In the 70s, we added chemotherapy. With chemotherapy, we saw that even without the amputation, the patients had similar survival, meaning we can just resect the tumor and save the surrounding structures. If we add chemo, those patients are going to have a good survival. And then, well, the medical oncologists are going to help us with the chemo, and the radiation oncologists will help us with radiation when indicated. So those are some of the things we consider when we see a bone tumor. We look at the MRI and we see, is this tumor encasing vessels? Is it invading the joint? Is it against like nerves? For instance, can we save the sciatic nerve in a leg or not? Because that's gonna dictate the function this patient is gonna have. There's no point in trying to do a huge effort to save a leg if we cannot keep the nerves or important vessels, because what is important is the function. Today, a patient may have a better function with a prosthesis and an amputation that with a leg that is not going to have its best function because we had to resect the nerves. So that's a decision we usually make with the patient and the family. So that's basically what we need to do. We have this bone that's invaded by a tumor, and that's the most common surgery that we do. We resect that part of the bone, and then we reconstruct it with metal. What you see here is what we call a proximal femur replacement. So we do this surgery where it's kind of like a normal hip replacement that you would do in an adult. But the standard of our resection is bigger because we are not following the rules of a hip replacement. We're trying to cut the tumor out. So luckily for us, we have very good prosthesis these days that I can, for instance, resect an entire femur or an entire humerus, and we have the metal implants to replace that part of the body. So I can take off the entire bone, put metal, and then attach all the muscles and tendons to it, and the person will have almost a normal life. If you see somebody walking with pants, it's hard to tell who has an implant and who hasn't. So this is very good news for our patients. As I was saying, there's a whole team treating those patients. We usually need chemo. We're talking cancer here. So these patients are going to need systemic treatment most of the time. Radiation may help in some cases. It's going to depend on the tumor. Some of these tumors respond well to radiation and others don't. So that's when the pathologists get in. They tell us what subtype of tumors. We're talking about, for instance, osteosarcomas. We have like 17 different subtypes, and they are based on what the pathologist is seeing in the microscope. So based on that information, we're going to decide what is best for this patient, what kind of chemo, what kind of radiation. Radiation and chemo also help us with the surgery, because once you do a resection after the patient has gotten chemo or radiation, it's easier to resect the tumor. They create kind of like a rubbery capsule that help us a lot. So that help us with the margins. It's going to help with local control of the disease, avoiding the tumor from coming back. Even when we take these tumors out completely, some of them still have a chance of coming back. So radiation and chemo do help with that. And chemo, of course, helps treating micrometastases, which are metastases that we may not see on imaging, but we know are there. So right now, there's a lot of research going on. We're trying to create a new targeted therapies. So, and we do have all these implants, like I said. So we do have much more hope for our patients these days. We're improving systemic treatment. We do have the implants to reconstruct. So we're able to do bigger surgeries without doing mutilating surgeries to the patient. So people are able to live longer because of the systemic treatment and keep a good function. And some of the things people are looking into, because these tumors is not just the bone or the cartilage. There are other cells that we can see in the microscope, and people are trying to target all those cells that we've seen as well. For instance, the vessels within the tumor. We have drugs that are going to attach to the cells that feed the vessels that may spread the disease, for instance. These are just the trials that are going on right now for osteosarcoma. There are many, many trials going on. We found different cells, different receptors, different genes that we can target in these tumors. And the future is looking much brighter for these patients, because we are finding all these mutations that are targetable. The thing about these tumors, for instance, here what we're seeing is the mutations we can find. For instance, in Ewing sarcoma and synovial sarcoma, we do have a mutation that is present in all those tumors. Any patient with an Ewing sarcoma, we know that he or she's gonna have that mutation. So we can have a drug that's gonna help all the patients with Ewing sarcoma. Now, for instance, osteosarcomas that are very aggressive and they divide too fast, they don't keep those mutations. So what we see when we try to look for mutations is that they change. One patient with an osteosarcoma can look completely different from a patient with a different osteosarcoma. Those osteosarcomas are not going to be the same. They're not going to have the same mutations. They're not going to look the same under the microscope. We just happen to call them osteosarcomas because they both have osteoid, but the mutations are very varied. So it's very hard to find a drug that's going to help all those patients because they don't have the same genetic profile, unfortunately. And what's good for us, because as I was saying, this is very rare disease. Osteosarcoma is only 600 a year in the United States. But we do have a lot of other cancers like breast cancer and colon cancer. And what we're finding is that mutations that happen in those tumors can also be found in this type of tumors. For instance, I don't know if you guys ever heard, there's this mutation called PD-L1 that is found in lung cancer, and the new drugs are targeting that mutation. We found that in osteosarcoma. So some of our patients actually benefit from lung cancer drugs, and their tumor can be treated with those drugs, which are much nicer to the patient because the chemo for osteosarcoma is very hard to tolerate. And luckily for them, if you find that the patient has that mutation, you can give a different kind of drugs that are easier to tolerate. So that's the good thing about these tumors. They're very rare, so we don't have a lot of them to study and to look for mutations and targets. But targets that are found in other tumors can be found here, so we can use those drugs. That's the good thing about it. So I just want to thank you all for attending here today. I hope you enjoyed the presentation, and if you guys want to ask any questions, I'm happy to ask them. Thank you so much.
Thank you so much, Dr. Balcereno. What a phenomenal synopsis of what it is, a very complex type of specialty. We do have a couple of questions. Interestingly enough, today we've been joined by someone in Malaysia. I'm trying to get the name of the university in Malaysia. Okay. But he is saying, or she, it's, will you prefer chemotherapy or radiotherapy for Ewing sarcoma in addition to surgical resection?
So depends on what we're talking. So for if you're talking about addressing the disease systemically, we need to do chemo. That's it. There used to be an option in the past where patients will get what we call total body radiation. So we're talking this tumor is growing in the cells that produce blood within our bones. So we will completely shut down the bone marrow in our body with radiation. We will radiate the entire body. And that was an option in the past. Right now, here in the United States, I think people are favoring just doing systemic treatment. So what we do is chemo, and that can actually shrink the tumor. Then we do the surgery of a much smaller tumor, and then we give chemo again. That's the protocol for Ewing sarcomas right now. In cases when we cannot do surgery because it will be too morbid, for instance, a patient with an Ewing sarcoma that is taking half his pelvis, there's an option for radiation Right now, people are trying some trials with proton therapy, and that's helping control the disease. Yes. So, but
in fact, I was going to bring up the proton treatment because, yes, it was said that Ewing sarcoma will respond phenomenally well to proton, yet it hasn't necessarily been grabbed by the tail and said, you know what, we're going to treat it with proton. So in your experience, proton is not necessarily a response, a good response to it, or is it mediocre response?
so I think it's more like a cultural thing. People don't feel comfortable with tumors inside the body. So if we have the option of taking it out, it's better to, yes, it's better to do surgery. We can use radiation as an adjuvant. For instance, as I said, if a tumor is in a very difficult location, I'm not sure about the margins, we can add radiation to that, and that definitely is going to help us. Ewings do respond, but there's nothing like a good surgery. That's what's gonna give the patient the best outcome. Yes.
Yeah. Also from Malaysia, and chemotherapy needed to be done. Is chemotherapy needed to be done after fixation for pathological fracture secondary to metastasis, metastatic bone disease, or only adjuvant radiotherapy is done?
Well, okay, let me see. Because okay, what we're talking about Ewing, metastatic disease. I'm not sure.
I suppose he's talking about metastatic disease in general. After the patient incurs a pathological fracture secondary to a metastatic disease of bone.
Okay. So I do see a lot of patients with metastatic disease, and they usually undergoing systemic treatment anyways, because if you're talking metastatic, we're talking about a lesion that has come from other sides of our body. So the disease, we assume the disease is spread. So those patients are getting systemic treatment. Can be immuno, can be CAR T cell, can be regular chemo, but they're usually getting that. So what we're trying to do in that kind of situation is give the patient his function back. So we're gonna try to fixate the bone if we can. That's gonna depend on what tumor are we seeing. Some tumors, so remember the tumor has invaded the bone, so I have to look at the x-ray and see how is the extent of that invasion. Do I feel confident that bone is gonna grow again? Because it's like a fracture. So you need to put the pieces of bone together and you need callus to form. Is tumor extended enough that I don't feel comfortable waiting for that bone to grow back? Then I'm gonna do a resection. Then I take it out and I put a replacement, like a proximal femur or a total femur or whatever it is that I'm thinking. And then I'm gonna see what kind of tumor are we talking about. Some tumors respond more to radiation. For instance, multiple myeloma, lymphoma, breast cancer, they're good responders to radiation. So I'm gonna add radiation to that, because in addition to my fixation, I can kill the tumor that's in the bone, and that's gonna help my fixation to last longer. Now, if it's lung cancer or renal cancer, I'm gonna see the extent of the tumor. Is it worth trying a fixation that I'm gonna depend on the bone to grow again when I know radiation is not gonna be that helpful, or should I just go ahead and resect that part of the bone and then just recreate it with a metal? So it's gonna depend on a lot of factors: the type of tumor, the extent, where is it located? Because if it's in a joint, I may not fix it. I just may do a joint replacement, because that's gonna be the best. It's gonna give the best function to the patient.
Wow.
Yeah.
We're happy to be joined by Dr. Marcos Nunez, who is a dean of Universidad Iberoamericana in Dominican Republic. So we're bringing him back to this continent.
Oh.
He has a question, and he says, when you do a curettage of a bone graft, what is your experience with autologous cancellous bone versus bone substitutes?
Well, again, it's gonna depend what tumor are we talking about. The most common situation, which I think he's talking about, is, for instance, a unicameral bone cyst. So the problem with, or simple bone cysts, they're synonyms. The problem with those tumors is that they thin the cortices. So the cortex is very thin. So you have to think, I can use autologous bone graft. It's okay, it's an option, it's valid. The problem is if I take bone out of the iliac crest, for instance, I have to impact it in there, and I have very thin cortices. Now, do I want to fracture that? No. So in those cases, I rather use substitutes. They look like toothpaste. It actually looks like that. It's like a toothpaste material. You put it within the hole you're gonna create in the bone after the curettage, and it hardens like cement. And the good thing about those is that in the lapse of about 6 months, they reabsorb and they give the bone, they still maintain the osteoconductive properties, so bone can grow back in there, normal bone, our own bone. So I rather use substitutes in those kind of cases.
Great. We have a question from, and they're rolling up because there's so many questions here. I have a question from Anahuac, which is a university in Mexico. And Fernanda Ramirez says, hi, are there any treatments related to genomics, especially mentioned in the part of cellular pathways diagram in the sarcoma treatment?
Well, so there are over 100 types of sarcomas. What we do have right now are certain targets that we do know, like the PDL1 mutation I was talking about. That's basically what we have. So remember, we are talking about very rare tumors. We don't have a lot of research in those tumors. So we're basically taking what we learn from other cancers and try to use it whenever we can. So one of the things we're doing right now, big cancer centers in the US are looking, every time we resect a sarcoma, they look through a panel of potential targets that we know and we have drugs for. So we can find a sarcoma that has a breast cancer receptor, and then the patient is going to benefit from that drug. And the problem with sarcomas is they're very they're heterogeneous. So the mutation you're going to find in one patient, you're not going to find it in another patient. So it has to be go by one by one. So we don't have universal targets, but we do look for them, and if we have a drug that's available, yes, we use it for those patients. Yes.
Fantastic. Sydney Rovello is from Universidad San Judas Tadeo. I want to guess it's Costa Rica. If a child had an osteosarcoma and he is cured, does the person as an adult have a higher risk of developing cancer again?
Not from the osteosarcoma, and also it depends. That's an interesting question. So there is a type of osteosarcoma that is related to a genetic mutation called RB mutation. The patient can have a higher risk for tumors related to that mutation. There's also a disease that's called Li-Fraumeni syndrome. Those patients can also have osteosarcoma, but if you have that mutation, it's not the osteosarcoma the problem, it's your mutation, and that mutation gives you an increased risk of having different types of tumors, like leukemia, lymphoma, solid tumors, but it's the mutation, it's not the osteosarcoma. Now, if we are talking about an osteosarcoma not associated with any mutation in particular, then your chances are the same as any other adult. The people are asking smart questions. So there's one thing, there's a detail. In the past, some big cancers where cancer centers were giving a lot of chemo, just because not everybody responds the same. So those patients later on, they found out those patients had a higher risk of developing leukemia later in life because they got so much chemo that causes leukemia later on. It's not the case with the kind of protocols we have right now. So I would expect a patient with an osteosarcoma to have the same risks of having prostate cancer or lung cancer as any other adult.
Sure.
Yeah.
Dr. Nunez, thank you so much. He says, excellent talk. Congratulations, Dr. Balcerena.
Thank you.
And thanks to Baptist Health International for the opportunity to be updated beyond COVID-19. I think that we have taken so much of our energy and time dealing with COVID. But as we wait for more questions, hopefully a few more before we sign off, in your experience, doctor, these tumors, obviously, we know that they are rare and far in between, and we don't have many. You mentioned 600 or so in the United States alone. Is there a tumor in particular that comes to mind that you say it is more of a particular country, let's say the Southern Cone, for instance? Have you, in your experience, encountered those type of tumors more often than here in the United States?
I don't think there's a geographical preference. for those type of tumors. What I see, because like you said, I trained in Uruguay, I trained in Brazil. What I found there, it was that caught my attention was a delay in diagnosis. So I will see a huge osteosarcoma that I would never see here, or a huge Ewing sarcoma over there. And I remember during my training, we would do crazy surgeries. I mean, the sizes of the tumors we would resect, they were absurd. And that's something I don't see that often here. It's a cultural thing. I mean, it's different. I think that's the reason behind it. But I don't see a geographic preference for the tumor itself.
If I was to ask you, Dr. Rosarena, what are you excited about the future to see in your specialty? What is it that it's really motivating you to look forward to in the treatment of these cancers? Obviously, you guys have come a long way in treating these conditions, and it has been such a horrendous past 30 years in regards to sarcoma, especially in children, because of the obvious reasons. Now, what are you looking forward to seeing?
So I think a lot of people are excited about immunotherapy and the new drugs. I'm excited about something different. There's an area of medicine that's quite new and recent that's called radiomics and artificial intelligence. And to be honest, that's what I think is the future. So, for instance, when I was in fellowship, we did some research where we tried to train a computer to recognize patients that were gonna respond to chemo versus those who were not gonna respond to chemo. Because like I said, those tumors are very different. A patient with an osteosarcoma is completely different from another patient with an osteosarcoma. So as of now, we have the same treatment we give everybody, but not everybody responds, despite having the same osteosarcoma. So one of those things that radiomics can help us with is predict who's gonna respond and who's not. Because there's no point in giving 3 months of chemo to somebody and burning some bridges and losing time if we know the person is not gonna respond. So I think that's the future, artificial intelligence.
Oh my goodness, we can't wait. You probably will have to visit MIT and start working on some of those beautiful technologies. We have one more question and then we can wrap it up. Actually, two more questions. Is adjuvant radiotherapy required following amputation and treatment of sarcoma?
Depends. It all depends. Because remember, sarcoma, we're talking, when you say sarcoma, I'm thinking 100 tumors. So if the tumor was localized, meaning it was only there, it did not spread to lymph nodes, to other sides of the body, and I did an amputation, and the pathologist tells me your margins were negative, I don't need to do radiation because I'm gonna be radiating normal healthy tissue, and radiation is good. It helps us a lot. But if, for instance, if you radiate a kid, it's been shown that you live enough years for that radiation to create a new cancer. So if we don't have to give it, we don't. So if I achieve negative margins, meaning I know I took the tumor entirely and the tumor was just there, then I won't give radiation.
Great. Let's go back to Ecuador. I love the Southern Cone. Hi, it was such a great lecture. I have a question, and this is Sarah Lamb, and Sarah Lamb is in Universidad Católica Santiago de Guayaquil. And she says, speaking of sarcoma, why is epithelioid sarcoma often mistaken for a benign injury?
Well, basically, it's a superficial tumor. It grows slowly. So, and there's a lot of these tumors that are mistaken for trauma. There's people sometimes they don't notice something's growing because it grows so slow and it's not causing you any symptoms. And then one day you hit your ankle or your elbow, and then you touch it, and oh, there's something there. But maybe it was there before the trauma. The right thing to do is just to get an MRI. If you got an MRI, you can tell it's not trauma. But because they are superficial, because they're in the skin, because they're very slow growing, because sometimes they are near the joints, and that's where you hit yourself in the elbow, in the knee, that may be a reason for it. But if you see it on the MRI, you can tell it's not a hematoma, it's not an abscess, it's not a scar, it's not a desmoid tissue tumor that can happen after trauma. It's something else.
Right. Well, we have a question from Peru, a young physician in training. Ana Patricia is from Universidad Peruana de Ciencias Aplicadas, and she says, good evening. I'm a medical student from Peru. When we talk about pain in advanced osteosarcoma, what are the analgesics used in these type of cases?
Okay, so that's again very interesting question. So you have to see what's the cause of the pain. So we do have you can have pain because the tumor is weakened your point to a point that the bone is about to fracture, and that's what we call mechanical pain. And the best way to prevent that pain is either taking your weight out of that limb or just addressing it with surgery. That's one thing. The other thing is many of those tumors, they produce prostaglandins because of the interaction they have with the hosting bone and with the surrounding cells, they produce prostaglandins. So NSAIDs are very good. Now, because sometimes these patients come and we tell them, oh, I just got ibuprofen, and it's like, ibuprofen? Like, why are you not giving me something stronger? But sometimes you don't need it because the mechanism of the pain is going to be depending on prostaglandins, and an NSAID is what's going to be most effective for you. Now, sometimes pain gets to a point that is much worse when these patients have pain at night and the pain is caused by the increased pressure in the bone. Those are the kind of pain that I would consider giving narcotics. Those, yes.
Okay. One last question. And this is from David Wong. I don't know where he's from. He probably will tell us later. But hi, is there a hereditary component toward these type of cancers? And if so, what would be the appropriate age and management for screening? Thank you so much for the great lecture.
Oh, thank you. So if we're talking just a tumor that is not part of a syndrome, just an osteosarcoma that happened out of the context of a syndrome, a chondrosarcoma that just arises de novo, then no. But like I said, those patients with, for instance, with multiple osteochondromas, those patients can develop chondrosarcoma. And the multiple osteochondromas is the genetic part that you can transmit to your children. And by that, you're transmitting that increased risk of a chondrosarcoma. But if you have just one chondrosarcoma that happened, it arises in a normal healthy bone, then no, there's no genetic component, and there's no transmitting those tumors to your descendants. No.
Well, these guys have phenomenal questions, and I know that you have piqued everyone's interest. So time is over, and I want to be considerate to you because of obvious reasons. So on behalf of our Baptist Health International, the entire team, I want to thank you, Dr. Rosarena, for this incredible presentation, and to all of you for participating and attending today's lecture. If you have any additional questions for Dr. Valserena, please feel free to send them via email at international@baptisthealth.net. We will make sure to forward those to Dr. Valserena so we could answer them back to you. We look forward to seeing you all in our next medical lecture, which is scheduled for Wednesday, September 16th. Thank you once again. Please stay safe and have a great afternoon. Thank you, Dr. Valserena. Have a great evening.
Thank you. Bye-bye.